Hello.
Good evening, sir. Santosh here. A very good evening.
Hello, Ravi.
Good evening, sir. Good evening, Gupta, sir.
Good evening, Ravi. I think his mic is not working. Can you hear me at least?
Yes, I can hear you, sir.
Okay. Hi. Good evening.
Good evening, good evening.
Because I also welcomed him, he didn't respond. So I think his speakers are an issue. Dr. Gupta's speakers.
Hello. Can you hear
Hello,
me now?
sir. Good evening. Yes, we can hear you now. Clear.
Yeah. Okay. Just for checking, I thought I'll connect first and see whether so everything looks fine.
Great, sir. Good evening, everyone, and welcome. So, anybody from USI who is coordinating this meeting?
Yes, sir. Good evening.
Yeah, good evening. Hello, ma'am. So, you will have to make all the faculty as co-hosts.
Definitely,
Because otherwise,
sir.
yeah, I think you're separated. Yeah, you're doing it. I could see that now. Yeah.
Hello, Ravi. Hello, Santosh. Good evening.
Hello, hello.
Very
How are
good
you?
evening. I think we should request all the presenters to open up their presentation and keep it ready and minus it and keep it on the desktop. I think we are very far ahead in the online thing and everybody is used to it. But just in case
NPG, good evening.
Good evening. Hello, Amit.
Hi. Hi, good evening.
Good evening. What is the
Thank
news
you for
in
joining.
Calcutta?
This is our first meet. Sorry.
What is the news in Calcutta?
News is hot, sizzling.
Hot.
Lot of things happening.
Lot of We are watching television, so we know what is going on.
Good evening.
Hi, Jagdish. Good evening.
Hi, good evening.
Sir, good evening.
Good evening, sir. Good evening.
Jagdish, good evening.
Good evening. Good evening.
Good evening, Kulkarni, sir.
Thank you. Thank you.
Sir, good evening, Kulkarni sir and NP Gupta sir. Good evening, Ravi.
Good evening, Mahendra. How are you?
Fine, sir. Fine, sir. Dr. Abid, good evening.
Good evening. Good evening.
So,
Today,
for those who are
Zoom
actually
giving us the memories of our COVID time. After a long time, we are having Zoom meeting.
Yes,
And
yes, yes.
I still debating in my mind whether we should have physical or we should continue with these Zoom meetings also.
You see the new regulation that has come in for conference sponsorship. There has been a lot of restriction from the government side. So
Yes.
we will be forced to do a lot of virtual conferences.
Yes.
Yeah.
For our conference, sir, I hope you have a society which is 12B or something to which you can take the pharma money for the conference. Otherwise, you will not be able to do a conference. This is for Dr.
No, people are working on it. So, Santosh, people are working on it. We are trying to find this. We should not put anybody in trouble, not only ourselves. We should not put the pharma in trouble. We should abide by the rules. And we may take advantage of some snags in the rules. If it is not, then we go virtual.
So
Isn't
I
it,
think
Jagdish, what do you think?
not required. We just did our master class. We just had another conference in Delhi. As long as
Yes.
you have an account in which the pharma could pay, and from there you do all the activity.
Yes,
It will be on that account, then it will be the best. If you don't have, then also I think just that GST-IN and all those issues you'll have to sort out.
No, Santosh,
Yes.
Santosh, it is not that easy actually. We have a lot of discussion going on for UC-Con Delhi. I am talking now because pharma is ready to give money to the company. Now the problem with the USI is, if suppose there are 800 delegates, they cannot make all the 800 as a faculty,
Faculty, yeah.
And hotel accommodation is the big problem. Registration is no problem, but now everybody is ready to pay the registration. So I had a discussion with the honorary president and secretary about all these things, but it is not that easy. What Amit is saying is right. We have to find out some other solutions.
Agree.
Otherwise, ED will do some inquiry or something like that.
No, you see.
That's happening in Calcutta at the moment. You never know.
ED is very active in Calcutta now. Very, very active. You see, the problem is, NPG, the problem is the conference will go smoothly. You see, this is the real danger. The problem will come on 31st of March when you are supposed to do the return.
Exactly.
So,
you're right.
This is the biggest problem. Yes. You may not realize during the conference. The conference will go smoothly and then suddenly you will be slapped with a lot of taxes, both the farmers and the organizer, both of them.
And then you will get a message that you owe this much penalty.
Yes. So this is the biggest danger. So we are working on it let us see what happens.
So one thing that the past used to happen, that directly pharma used to be interested in sponsoring the doctor directly. That probably will not happen.
That is gone.
It may still happen through a third intermediary, means through some event manager or something, but it cannot happen directly.
It cannot happen. No, the sad part is, I don't know what to comment about it. NPG sir might be able to enlighten. The doctors are not ready to dish out either the 20% tax or their PAN card, or leave alone pay for themselves. This is the problem. Sir,
there is
neither of them.
There is a technical problem. There are people like us whose salary is, if the amount of tax 20% we have to pay on everything, it will be more than my salary because we get peanuts. So there is no way you can do it. It's not economically viable.
Dr. Santosh, you are online.
It's not recorded right now, right?
I don't know.
No, what I'm telling is, it is just not
possible.
There are people I know who are traveling every weekend, and the amount of everything on their PAN card, if it comes, it is impossible to.
No, Santosh, you have said you've made a very fair statement. But people who are working and with huge amount of practice, etc., they are also not prepared to pay for themselves or even dish out their PAN card or even pay 20% tax.
See, Amit, what I was also working in All India Institute of Medical Science, and till 1998, I think so, the pharma were not in the picture at all. Till that time, I know most of us used to pay our registration. We used to make our own arrangement for travel. At that time, we used to travel by train only. And we used to stay in guest house, government guest house, or wherever the accommodation is arranged like that, or even the medical college hostels we have stayed. So I have stayed like that throughout my life between 75 to 98. After 98, unfortunately, the one pharma started, then second, third, fourth. And now today what has happened? The reality is what you said is perfectly right, that nobody want to shell out money from their own pocket, until unless they are forced. Like registration, they are not paying, but for accommodation and travel, it is not only alone, with family, with children, they are having a social outing on the name of the conference and all that.
And the biggest irony is they come to the conference and go out for a holiday.
Yes.
And the halls are sometimes left
So,
empty.
all not trying to attend.
Nitin, good evening.
Nitin,
Just a gentle reminder, we are 3 minutes
I
into
think
the
the
starting
time,
meeting.
we can start now. If you have time there.
It's
7:30. 2 minutes.
Dr. Samnis was not well, is what I heard. I wonder whether he'll be joining.
Shravan, good evening.
Good evening to all.
Ranjan, good evening.
Is Dr. Keshav online? For the opening remarks he has to give.
Yeah, Keshav is here. Keshav, good evening. Are you here?
Dr. Keshav.
Yeah.
Shall we start?
No, sir, we'll start exactly at 7:30.
We have 3 more minutes, sir.
1 minute.
No, 3 minutes more.
Sorry.
In Calcutta, it's 7:30.
No, my watch is always correct. It's
7:27.
Google runs the time every day, sir. Not
Second
constantly.
is always right.
Hi, Sanjay. So for all,
Dr. Sabnis joined in.
No, he's not well, so he may not join.
I tried calling him, he didn't pick up the phone.
I had a communication from him that he's not well, sir.
Oh, no, he is well. He is not able to travel. That is all. Otherwise, he's all right. I spoke to him.
Okay.
Good evening, Hujur.
Good evening, sir.
Hi, Dr. Viswanu.
Good evening, Dr. Nitin.
good evening, Dr. Uttamdar.
1 more minute.
Yes, so I could see that there's a time of starting written 7:30. Onwards, how long it will go? Dr. Kulkarni, sir.
If everyone sticks to time, it would be finishing by 9:15, sir.
There's no end of discussion. We'll keep on.
That's the only role I'm going to play, being moderating and
Ravi Mohan, when are you going to finish?
Sir, around
Good
9
evening, everybody.
100
Good
100
evening,
minutes
everybody.
program.
Hello, we'll have to start. Good evening. We'll have to start. Good evening, everybody. Welcome to this inaugural webinar from the UroOncology section of the Urological Society of India. I must congratulate all the 4 conveners who have put together a good scientific program for tonight, Dilemmas in Bladder Cancer, which will be moderated by Dr. Ravi Mohan from PGI Chandigarh. And the other conveners are Dr. Amit Ghosh, Dr. Ganesh Pakshi, and Dr. Santosh Kumar. So I would now invite Dr. Ravi Mohan. I think Dr. Sabnis is not joined in. So I would now invite Dr. Ravi Mohan to give a brief overview of this session and then moderate this webinar. Over to you, Dr. Ravi Mohan.
Thank you, sir. Thank you very much for this opportunity and my co-conveners for this program that we were able to talk out. So the theme for this program today is dilemmas in bladder cancer. For want of time, we will not waste in presenting a case and then discussing about it. The program has been designed in a way that two experts will be speaking on point and counterpoint about a particular situation or a question which we encounter in our day-to-day bladder cancer management. And then we would have two experts who are very senior experts who would give their experience-based comments. So that's the format of the program. And the only request I would like to make to everyone is that please stick to time so that we finish it in time and we can have a good dinner and enjoy the program thoroughly. So with that few words, let me start with, so we have 5 dilemmas. Each dilemma would be about 20 minutes. So we would start with Professor N.P. Gupta sir and Dr. Jain Kulkarni sir, that they would introduce the first two or they would invite the first two speakers for point counterpoint, and then followed by they would be giving their expert comments. Over to Gupta sir.
So Jagdish, you can start because my mobile phone is with my grandson. So Jagdish, you can start.
Jagdish, you're on mute.
So, sir, I will do that. I will do that for you. So, first scenario is generally always the question remains that whether we should do a standard node dissection or extended node dissection in managing our bladder cancer during the radical cystectomy in muscle-invasive bladder cancers. So, we would have 2 speakers, Dr. Brushabhanu Nayak from AIIMS New Delhi. He would be speaking for extended node dissection. And this will be followed by for 8 minutes and followed by Dr. Prashant Naik from AIIMS Bhubaneswar. He will be speaking on role of standard node dissection. Over to you, Dr. Brusabhanu.
Thank you, Dr. Ravi, and thank you, USI, for this opportunity. So today, the topic of the debate is the extent of the lymph node dissection during cystectomy. I'll be speaking in favor of the extended lymph node dissection. So before we move on to the extent of the dissection, the lymphadenectomy with radical cystectomy, as you all know, is the standard of care for the muscle-invasive bladder cancer, and up to 25% of the patients with lymph node metastasis actually have lymph node metastasis at the time of the cystectomy. The staging and the therapeutic role of lymph node dissection is well established. The only controversy remains what is the extent of the lymph node dissection, and that's the topic of the debate today. So before you go to the extent of the lymph node dissection, first let's discuss regarding the lymphatic drainage of the bladder. The primary lymphatic drainage of the bladder is internal iliac, external iliac, obturator, and pre-sacral lymph node. The secondary lymphatic drainage being common iliac, para-aortic, interaortocaval, and para-caval lymph nodes.
Now, Nayak, your slides are not moving. Can you make it full screen and then move the slides? Sorry for that interruption.
Should I do
Yeah,
it
we
again?
can only see the yeah. Your slides are not moving. It's not full screen either. Can you reshare? Yeah, now it is good.
Yeah.
Thank you.
Is it okay now?
Yeah.
Yes.
Okay, so this is a schematic representation of the lymphatic drainage of the bladder. Depending upon the bladder cancer location, if you can look at this diagram, the lymphatic drainage varies from the site of the bladder cancer origin. So the therapeutic and prognostic significance of the lymphatic lymph node dissection in bladder cancer is the lymphatic lymph node status is a powerful predictor for cancer-specific survival. 70 to 80% of patients with the lymph node positive disease experience recurrence. Also 30% of patients without having lymph node positive disease, they also do develop recurrence. So the therapeutic benefit of the lymph node dissection is well established, both in node positive and also in node negative disease. Regarding the role of the number of the lymph nodes during the lymphadenectomy, there are different actually studies that have happened on the threshold of the lymph node count on the survival, because the lymph node count itself is the surrogate of the extent of the lymphadenectomy and also an important prognostic factor. The listener et al. Actually have shown in their studies 16 lymph node is the threshold lymph node for the survival. If you remove more than 16 lymph node during lymphadenectomy, the 5-year survival is 65%. If you remove less than 16, then it is 51%. Similarly, in Harihar also, they have given 14 is the adequate lymph node number for the lymph node adequacy of the lymph node dissection. If you remove only 5 lymph nodes, the 5-year overall survival is only 30%. And if you remove more than 14 lymph nodes, the 5-year survival is up to 80%. Similarly, there are others also, those who have given the threshold of 25 and 16. So different actually, on a consensus basis, more than 15 lymph nodes is the adequate number of the lymph node one should remove during the lymph node dissection. The controversy on the optimal anatomic boundary of the lymph node dissection is because of the conflicting data regarding the anatomic distribution and the pattern of the lymph node metastasis. So to define the boundaries, there was one landmark pathoanatomic study was done by Listener et al. And it was published in Journal of Urology in 2004. So in that particular study, he has actually divided the level of the lymph node in bladder cancer into 3 levels. Level 1 is till the bifurcation of the common iliac, level 2 till the bifurcation of the aorta, and the level 3 is beyond the aortic bifurcation. What he found, approximately 7% of the patient had only level 1 lymph node metastasis. Another 7% of patient had only level 2 metastasis without having any level 1 metastasis. However, he found there was no patients with only level 3 metastasis. That means there will be no patients, those who will be having only level 3 without having level 1 and level 2 lymph node metastasis. Hence, he actually recommended to do a lymph node dissection till aortic bifurcation for accurate staging. So there are different nomenclature for the lymph node dissection of the bladder cancer, like limited lymph node dissection, standard, extended, and super extended. Limited lymph node dissection is when you do a lymph node dissection only confined to the operator fossa. Standard, the lateral limit is the genitofemoral nerve, medially it's bladder, cranially till the crossing of where the ureter crosses the common iliac, and caudally it's still the cloacaed lymph node. This is the standard lymph node dissection. Extended is when you proximal limit is extended till aortic bifurcation, and super extended is when you proximally extend it till the origin of the inframagentic artery. With this nomenclature, let's see. Look at the impact of the extent of the lymph node dissection on oncological outcomes. This was one beautiful systematic review published in European Urology, where the authors actually tried to find out the different studies that are available on lymph node dissection. What they found total of 7 studies comparing no lymph node dissection with lymph node dissection. That lymph node dissection could be standard, extended, or super extended. What they found, if you do a lymph node dissection, there is a benefit in overall survival and cancer-specific survival. However, there was no comparison in those studies regarding the perioperative outcomes. And in this particular review, they did not find any study comparing limited and standard lymph node dissection, but they did find 5 studies comparing limited and extended lymph node dissection. So out of those 5 studies, the 3 studies have shown there is an improvement in the oncological outcome if you increase the extent of the lymph node dissection. However, in another 2 studies, there was no difference in the oncological outcome. Regarding the perioperative outcome, one study has shown extended lymph node dissection actually doesn't increase the prolonged operating time. There are limited lymph node dissection, but if you do a super extended lymph node dissection, then there is an increase in operating time. However, there is no difference in the blood transfusion, 30 days complication, and lymphocyl depending upon the extent of the lymph node dissection. Similarly, they also found 7 studies comparing standard lymph node dissection with extended lymph node dissection. And in those 7 studies, 4 studies, there was no difference in the oncological outcome if you do either standard lymph node dissection or extended lymph node dissection. But in 3 studies, there was a benefit on oncological outcome. However, there was no difference in the perioperative outcome. So from this systematic review, it has been found there are studies those who have shown if you increase your lymph node dissection, like the extent of the lymph node dissection, it's a mixed result. Some studies are showing if you increase the extent of lymph node dissection, there will be oncological benefit. Some studies are also saying there will be no difference in the oncological outcome. However, there is no difference in the perioperative outcome or perioperative complication if you increase your extent of the lymph node dissection. Finally, the most recent, there are two randomized control trial. One is from Germany, the LA trial. The results of that particular trial has already come. But in this particular trial, they compared the standard with the super extended lymph node dissection. And in standard lymph node dissection, the average lymph nodes are 19. In super extended lymph node dissection, the average lymph node was 32. However, there was no statistical significant difference in the recurrence-free survival and cancer-specific survival, whether you do a standard or in super extended lymph node dissection. There is another landmark RCT from SWAG trial comparing the standard and the extended lymph node dissection, which is ongoing. And the results of that particular trial is likely to come in near future because the trial is completing in next month in August 2022. But if you look at these two particular trials, the LA trial actually, there is no neoadjuvant chemotherapy was allowed in this particular trial, but in SWAG trial, neoadjuvant chemotherapy is allowed, which is the standard of care nowadays. And also in LA trial, the experience of the surgeon was not considered. Anybody can participate in this particular trial, but if you do a SWAG trial, there has to be a minimum experience of the surgeon, and the surgeon has to be a certified surgeon for this particular trial. So, comparing these two trials, the SWAG trial actually seems to be more better designed, but the result of that particular trial has not yet come. So, finally, I'll tell, looking at the retrospective studies that are available and the existing randomized trial that is available, though there is no clear-cut answer whether one should do extended or standard lymph node dissection, but there are retrospective studies which are available which shows if you increase your extent of lymph node dissection, that is going to have some oncological outcome. At the same time, there are studies, those who have shown there is no difference in the oncological outcome, but at the same time also, if you compare the perioperative outcome, there is no difference in the perioperative outcome. So in one hand, there is some improvement in your oncological outcome in some studies, but without adding more morbidity. So it's only the common sense will tell actually if there are studies, those who are saying if we increase your lymph node dissection beyond a certain number, if your 5 years survival, cancer-specific survival is going to improve. So I would only argue actually one should increase the extent of the lymph node dissection for a better oncological control, though there is no clear-cut consensus till now. So the final conclusion would be any lymphadenectomy is better than no lymph node dissection, and extended lymph node dissection might improve your oncological outcome, but extending the lymph node dissection beyond extended lymph node dissection till the super extended lymph node dissection is unlikely to benefit. As per the listener, the Anatomic study, there will be no patients, those who will be having only lymph node metastasis beyond the RD bifurcation. So there is going to be no benefit by increasing beyond RD bifurcation, but I would recommend doing it at least till RD bifurcation. So one should do an extended lymph node dissection rather than doing a super extended lymph node dissection. But still, the jury is still out of the topic. Thank you.
Thank you, Dr. Nayak, for that great presentation and your sharing your clear thoughts. So I would invite Dr. Prashant Nayak from AIIMS Bhubaneswar to present his viewpoint on, and he will look for the standard node dissection.
At the outset, I'd like to thank US. Yeah, am I audible?
Yes, Prashant, you're very much.
Yeah. So at the outset, I'd like to thank USI and UroOncology subspecialty section for inviting me to this inaugural CME. So Dr. Prasavanu has already made the points very eloquent, and my topic is more or less going to be repetition of the above. Only thing I will be highlighting a few other points in addition to what Dr. Prasavanu has already told. So what is standard RC? We know that, as Dr. Prasad has told, that standard RC includes a lymphadenectomy, whether you do it in males or females. What is the proximal extent of this lymphadenectomy? It could be erectroileal crossing in standard. Extended, it goes up to the aortic bifurcation. super extended, it goes up to the inferior mesenteric artery origin. So that is as per the EU definition, although there are some trials which has taken, even the LIA trial has considered the extended, they have gone up to the super extended and inferior mesenteric origin. So, but this is what is the current definition of what is standard, what is extended, and what is super extended. The distribution of nodes already told. This was a 2010 paper, the Roth et al. Spuders paper, which said that if you go beyond the standard, that is go proximal to the urethral crossing on the common iliac, it's only about 4 + 4, 8% additional lymph nodes is what you get up to the inferior mesenteric origin. So that is about that. And lymphadenectomy outcomes, as you've already listened, lymphadenectomy is better than no lymphadenectomy. So whatever way, if the 10-year recurrence-free survival is up to 80% in lymph node negative, up to 60%. Still, let me just. Up to 60% in patients with extravesical but lymph node negative and 30% in lymph node positive. So it dramatically drops if there is lymph node positive. So this also indicates that if, and also there is evidence that if you do a lymphadenectomy versus not doing lymphadenectomy, that also improves the survival, whether in lymph node positive or in lymph node negative cases. Crossover lymphatic. So whether you should do bilateral or unilateral, some papers have come up initially which showed that the conclusion was the crossover lymphatic drainage is very common, and unilateral pelvic lymph node would have missed the radioactive lymph nodes. They have used detecting this radioactive lymph node detection, would have missed in 30%. So in most of the common practice now is to do a bilateral lymph node dissection, although the authors made a case that you could preserve the contralateral autonomic nerves by avoiding dissection on the contralateral internal iliac vessels in case the tumor is strictly unilateral. But again, this is not standard practice anymore. Right. So what is the role of lymphadenectomy? This I've already mentioned. There are consistent benefits in overall survival and recurrence-free survival for lymphadenectomy. There are smaller retrospective studies which have given definite OS and DSS benefits. If you do standard versus extended has got some benefits. But what about the larger trials? So this was a larger retrospective comparative study, which was 554 patients, 405 patients. They compared. Overall recurrence rate was equal at the two institutions. So one institution, they did only standard, and other side they did an extended lymph node dissection. So the authors had commented that meticulous extended lymph node dissection up to the mid-upper third of the common iliac vessels appears to provide survival recurrence outcomes similar to those of a super extended template. So this was a large retrospective that had told that it is similar outcomes between the two. But again, this was retrospective. So this was the prospective trial which Dr. Russa was alluding to. This was the LIA trial that came out in 2018. Again, compared in today's definition standard versus super extended. So only caveats to this trial is the 14% E1 patients, a large number of E1 patients, which could be a confounding factor because the benefit of lymphadenectomy would definitely be in the patients which have got a higher stage, T2, T3, T4. So, but these patients had a significant, this trial had a significant patient with E1. Again, this was an underpowered trial for non-inferiority. So this was not powered adequately. The positive surgical margin rates were very high. After radical cystectomy, in both the groups, it's about 9% positive surgical margin. So that puts into question whether the surgical acumen and the surgical skills or the surgical practice that was adopted in this trial. But what were the takeaways from this trial? They identified 2% of patients who had an exclusive para-aortic and paracaval lymph nodes. So lymph nodes above the aortic bifurcation was 2%. That means this patient did not have anywhere else any lymph nodes positive, and it was only in the para-aortic and paracaval, which would have been missed had we not done a super extended. That is one. 35% more positive nodes are identified if we do a super extension. They observed it trend, but no significant difference towards improved RFS and CSF. So they concluded that they did not find a statistically significant advantage, but they observed a trend towards more survival benefit in the super extended group. You know, there was a Cochrane analysis that came out immediately after that analyzed the single RCT. So that they took off a huge number of particles.
WhatsApp.
Excuse me. Yeah.
So everyone has to mute themselves, please.
One.
Yeah. So they took up a huge number of articles and finally rejected everything and did a Cochrane analysis based on this single RCT. So this single RCT Cochrane analysis, what it showed that, sorry, the extended pelvic lymph node dissection may reduce the risk of death from any cause over time as compared to standard PLND, although due to the certain biases, the certainty of evidence was less. So this is death from any cause. Again, death from bladder cancer also extended PLND may reduce the risk of death from bladder cancer. So these were the conclusions. They got extra data. They got they got the complete data sheets from the authors, and they did a reanalysis in this during this course of the Cochrane review, and they came out with this with his analytical results. So this question we have not asked. Can adjuvant chemoradiotherapy replace extended dissection like it has done in other specialties? They have explored this, whether it is true for gastric cancer, whether it is true for pancreatic cancer. Can we avoid doing an extended lymph node dissection if you give a neoadjuvant chemotherapy or adjuvant chemotherapy or adjuvant chemoradiation? So this question has probably not been answered in our urology or in CA urinary bladder. So as Dr. Brusha told, we are all looking forward to the SWOG S1011 trial, which is 658 participants. So 2022, August is the end of this trial. The significant part is that P1, which was a confounding factor there, has been excluded here. And 56% of the patients have received NSCT. So this is a real world scenario. As I told previously, whether giving neoadjuvant chemotherapy obviates the need to do extended lymphadenectomy. So this would be probably better answered either in the whole of the trial or in a subset analysis where you analyze the patients who have received NSCT. So the results will be out in the EAU 2022. Most likely they'll put out the abstract there, and that will throw out some clarity on this issue. Thank you. Thank you very much.
Thank you, Dr. Prashant, for that clear presentation. So may I invite Professor Gupta sir, followed by Dr. Jain Kulkarni sir, to share their experience and what do they think about this this aspect of management.
Thank you, Ravi Mohan. I recollect my experience of AIMS, where we have also published our paper of 450 cases of radical cystectomy with pelvic lymphadenectomy. Now, we have the standard practice of doing standard pelvic lymphadenectomy in all cases. However, in selective cases where if lymph nodes are palpable or something at the time of surgery, then one can go for extended. But there is no role of super extended lymphadenectomy because prognosis of the patient is not going to change. So I will say that the standard practice is to do at least up to the bifurcation of the aorta one can do. Otherwise, up to the mid iliac artery, that ilio ureteric junction, that level should be done. The other important thing is how many number of lymph nodes. I think so that made a major difference, and more than 14, 15 or 16 lymph nodes should be removed. That is the adequate number. If you are removing less than that, then it is not any good. The last point is Prashant, what he said. Now today the practice is totally changed. Even today I have a patient who had a solid tumor and we got a PET CT because our medical oncologists always like to have and he had a now lymph node, both pelvic lymph nodes as well as para-aortic lymph nodes are also there. So he has advised for FNEC. So if we know that lymph node is already positive, I think so these patients are going for neoadjuvant chemotherapy, and after that only we will decide whether he should go for surgery or not, even for surgery or lymphadenectomy, and what kind of lymphadenectomy. So neoadjuvant chemotherapy is going to change this scenario. Thank you.
Thank you, sir. Kulkarni, sir.
Thank you.
Good evening to everybody. And I would like to echo what Dr. Gupta has clearly said, that this is the practice. And the point which he brought out is that neoadjuvant chemotherapy has become, and you know, the impact of PET scan. PET scan has made so much life different, because we are trying to get this. We do not know what is the actual SUV value, where the node is to be taken as a malignant or non-malignant. And therefore, and medical oncologists, they are all fond of doing this neoadjuvant chemotherapy. So that has really proved the point. Now, having said that, one thing which I need to emphasize, in that is the triangle of Marseille. I think that is an area which needs a very careful dissection, especially at the level of bifurcation between the source and the. That is the area where most of the relapses do occur, or otherwise the pre-sacral lesion. So essentially, the not extended, but below the bifurcation of aorta and whole meticulous node dissection is the key word. Surely enough, that therapeutic benefit of this clearance will pay in dividends. Secondly, the amount of adjuvant therapy and better adjuvant therapy which are coming up in terms of targeted therapy are going to change this whole thing. So we're going to see another thing while we are awaiting the results of randomized clinical trial which will come in August 2022. I think the template will still be continuously evolving. We still don't have a standard template at this point. But I must compliment both the speakers. They really address the issue very well. Thank you very much.
Thank you, sir. I think those words of wisdom that the things are going to evolve as we move on with management of bladder cancer is probably true. Until we have an answer, I think meticulous node dissection should be the key. And yeah, thank you. So with that, we'll move on to the next dilemma. Now, with advent of robotic surgery and open surgery, now we have robotic open laparoscopic surgery and all sorts of surgeries available for radical cystectomy. So we thought let's have a small counterpoint on open versus robotic radical cystectomy. So for that, we'll have Dr. Giridhar Bora, who's from PJ Chandigarh. He would speak for robotic radical cystectomy and intracorporeal diversions. This would be followed by Dr. Mahendra Pal from TMH Mumbai, who will be speaking for open radical cystectomy. Dr. Bora, please.
Thank you, Dr. Ravi. Am I audible and my slides are visible?
Yes.
Yeah, thank you. So at the outside, I'd like to thank Urological Society of India and UroOncology subsection for this opportunity. And today I'll be talking on robotic radical cystectomy with intracorporeal urinary divergence. I know the intracorporeal divergence group is small and it is outnumbered by the open radical cystectomy group, but I request everyone to review the recent technology and recent data without bias, because this technique is still similar to open radical cystectomy with a minimally invasive way. If you look into the open radical cystectomy and diversion, that is the gold standard. However, the open radical cystectomy is associated with certain issues like this, and also patients are having pain, also delayed bowel recovery. And I also would like to address the training and learning curve in open radical cystectomy. Since the robotic cystectomy came in vogue in 2003, the intracorporeal diversions are picking up just because they have less blood loss and transfusion, smaller incisions, less postoperative pain. And also there is data coming up that shows that it also decreases, does less systemic immune stimulation and a faster bowel recovery, and which in terms correlates with the lesser hospital stay. And also there is data on equivalent oncological outcomes compared to open radical cystectomy. However, it is associated with increased operative time and cost compared to open radical cystectomy. The largest evidence comes from the RAGEL trial. This is an open-label randomized phase 3 non-inferiority trial from the Deepin Parikh group, where they compared their robotic cystectomy group with the open radical cystectomy group. Both the divergence were open in both the groups, and they found the blood loss and transfusion rates were significantly less in robotic cystectomy group. And in terms, the hospital stay was also less in the robotic cystectomy group. However, the operative time were significantly higher in the robotic cystectomy group. but the 90-day complications rate were equivalent in both the groups. And they further looked into the oncological outcomes of the robotic radical cystectomy, and they published the 2-year progression-free survival was equivalent in both the groups. And they subsequently published their 3-year data and also showed that robotic cystectomy is non-inferior to open cystectomy in terms of cancer control. And also recently a trial of open cystectomy with robotic cystectomy intracorporeal diversion was published in UroOncology, and they've shown that the robotic cystectomy with intracorporeal diversion is associated with significant higher in robotic cystectomy group. Now coming to how the intracorporeal diversions are better than doing open diversion, because the urinary reconstructive part is the major driver in morbidity in radical cystectomy. The bowel recovery still is a problem for open radical cystectomy group. And there is a data coming that the robotic cystectomy causes less stimulation of the immune response. There is less retraction, less bowel hemorrhaging, leading to early bowel recovery. And also bowel is not exposed to the environment, so there will be less third space loss and there will be less fluid imbalances. All these factors are helping the intracorporeal diversions, patients having a faster recovery in the postoperative period. And we also studies this finding in our studies. We in a non-randomized fashion, we looked into the open radical cystectomy and robotic cystectomy group, and we also measured at day 0, day 24-hour, and day 72, and we looked into various immunological, hematological markers, and we also we found that the robotic cystectomy group is having a significantly less rise in the IL-6, procalcitonin, and C-reactive protein levels compared to open radical cystectomy. However, the clinical outcome of this finding is yet to be defined. However, it is certain that it stimulates the immune system less compared to open radical cystectomy group. And there is a recent data from the International Robotic Cystectomy Consortium from 18 centers. It's a retrospective data where they analyzed the 30-day and 90-day readmissions rates were significantly less in the intracorporeal diversion groups. And if you look into these data, the most commonly the gastrointestinal and infectious complications were significantly less in the intracorporeal diversion group compared to the open radical cystectomy group. And now coming to the training, my open radical cystectomy people will say that there is our training issues in robotic cystectomy and everything. But if you look into both the surgeries in the open cystectomy, the surgeon, the assistant, and the other staff has been very review of the field, and there is difficulty in learning. You can find the layers of the non-millers, and we discussed with our residents. They say after watching this robotic cystectomy videos, even their open surgical skills have become better. They have a better understanding of the anatomy, pelvic anatomy, where are the vessels, what are the layers of the non-millers, where to go, and how to make your incision. So definitely the learning curve and training is less and training is better in robotic cystectomy group compared to an open cystectomy. And also we looked into our data of robotic intracorporeal diversions, and we saw there was significantly less operating time compared to when we compare our first 15 cases to the last 15 cases, is just because the surgical team is getting experience. It's not only the surgeon, it is the assistant, whole assistant staff, nursing staff, anesthetists, everybody is getting geared up for a big long hour surgery, and their operating time are significantly getting lesser and lesser the case by case. Also the blood loss is coming down. Here you can see in the middle we had a slightly higher blood loss, just because that with the experience we are embarking into more difficult cases leading to more blood loss, and which is subsequently with the learning curve is also coming down. And also it's one interesting finding we have seen. This is a case of robotic radical cystectomy with intracorporeal alveolar conduit, and he has a right ureteroalveolar stricture, and we again went in again, and we can see that there are minimal adhesions after robotic radical cystectomy intracorporeal diversions. And you can say they are any difficult and with a minimally invasive way. It is very difficult to find such planes after open radical cystectomy. But however, the robotic cystectomy is also should be taken with some caution, because there are reports of unusual metastasis like port site recurrences, peritoneal carcinomatosis, maybe due to the excessive, that is a head down position in pneumoperitoneum, and there could be excessive manipulation of the cystectomy specimen, or maybe more high grade and advanced disease are being operated by robotic cystectomy. And we also published such an unusual finding in one of our cases, and at 3 months follow we presented it in a axillary lymph node, and we excised that lymph node, and that came out to be a poorly differentiated carcinoma. So we should select our cases properly, and I think we should do limited volume disease by robotic cystectomy. And also there is one more caution, is the high cost of the equipment and due to the cost related to the increased OR time. And we are also not sure whether the improvement in perioperative recovery and the robotic competition that is coming up, new robotic systems are coming, the cost is going to come or not. But still the cost may come down in future. Therefore, I'd like to conclude that we have to select the best candidate and best center for a robotic cystectomy and intracorporeal divergence. Only high volume centers having a good experience in both open and radical robotic cystectomy should be taken in cystectomy, not like seen in this picture, having a very extensive disease with query rectal infiltrations. And also, I think the more obese patients will be benefited by this robotic cystectomy and intracorporeal divergence, because the wound-related morbidity will be very less after intracorporeal divergence. And also, definitely female patients having cystectomy, because there will be no incision for specimen removal, and the specimen can be removed through the vagina, having a minimal scar in the postoperative period. And thank you.
Thank you, Dr. Bora, for that very nice presentation and a very comprehensive presentation of the indications of where it should be done. With that, I think but centers like TMH, where there are high volume and access to robot is limited, or other factors, I would like to invite Dr. Mahendra Pal. He would be presenting about open radical cystectomy. How is it relevant in our scenario? Dr. Mahendra. Dr. Mahendra, you're not audible yet. You need to unmute.
So my slides are visible?
Yes, now we can see and hear you.
Okay. So thank you so much for the invitation from the USI and the UroOncology subsection group. So my topic is open radical cystectomy and diversion. So open radical cystectomy is the gold standard for MIBC and optional cases of an MIBC. Methods are transperitoneal, extraperitoneal. And that diversion, I'll conduct a neobladder, and approach can be open, laparoscopic, and the robotic assisted. So coming to the methods, transperitoneal, extraperitoneal. So Dr. Kulkarni sir who is a pioneer of extraperitoneal approach of RCIC. So this is the one paper which compared extraperitoneal and transperitoneal approach. And what they found that in transperitoneal group and in both the group, the operating time, hospitalization time, blood loss, and lymph node DL, all were similar. What is the difference between the extraperitoneal group is that the GI symptoms, GI complications were less compared to the transperitoneal. And they concluded that extraperitoneal has the advantage over minimizing the GI complication, but no advantage on the oral outcome and the operative difficulties. So let's have a small video on the transperitoneal cystectomy. And Dr. Bora Girdhar has shown a nice robotic video. Now this is how we perform open radical cystectomy, transperitoneal. So the planes are also very good for us. Again, the selection of the patient is the key. In this case, our blood loss was, cystectomy was 250 ml. Total blood loss was around 550 ml in whole surgery. The visibility of this patient was planned for neo-bladder. So we preserve the urethral length as much as possible. So this is the method of transperitoneal cystectomy. But cystectomy is just a part of the procedure. What next? Next is the diversion, either by the ileal conduit of the neobladder, again, extracorporeal or the intracorporeal. So what is the trend of diversion at present? So with the time, ileal conduit is decreasing and orthotopic neobladder is increasing. When we compare intraoperative restriction of open IC and the neo-bladder, so the study found that a conduit group has more intraoperative adenolysis and the rectal injury, because IC group has more T3 and T4 disease. Compared to a survival on the conduit and the neo-bladder, this study found that neo-bladder has better survival rate than the compared to conduit. Complication rate, long-term complication is more in conduit group and less in continent diversion. This study again compared with the orthotopic neo-bladder and the allocondic, and it found that it favors the alluvial neo-bladder as a diversion of choice. Now coming to extracorporeal, intracorporeal diversion, again open method. So as we see, most of the even robotic series, the diversion was done extracorporeal. And in 30 days mortality in the intracorporeal, extracorporeal, there is no difference. So one systemic review again shows that the complication rate in both the diversions, intracorporeal, are similar. However, intracorporeal diversion group has lower blood loss and lower blood transfusion rate. The awaited trial of IROC trial, which is again comparing the robotic intracorporeal or extracorporeal group, till now they also concluded that intracorporeal has a better recovery and less hospital stay, and there's no difference in overall survival and the cancer-specific survival. Now this is our topic: open radical cystectomy diversion in robotic era, where the open radical cystectomy and diversion stands. So what is the ongoing trend? Even at present, the maximum surgery done by the open method. But if you see the next table, the robotic surgery is increasing. Numbers are increasing with the time. So these are the few review articles which I'm going to highlight upon who compare robotic versus open radical cystectomy and accept operative time like blood loss, transfusion rate, and length of stay. The robotic cystectomy is beneficial. Lymph node yield again towards robotic surgery and complication rate toward robotic surgery. However, post-surgical margin has no difference in open and the robotic. Another systemic review studies these modality, and it says recurrence rate, outcome of mortality, and operative time. There is no difference, even more towards the open side. And surgical margin, again, it's equivocal. Again, it also says blood loss, transfusion rate, time to regular diet, and complication rate again favors robotic cystectomy. Razor trial, as Dr. Girdhar also mentioned, that no presentation will be complete without this trial. There's a non-inferior trial about robotic or open cystectomy, and it shows that the perioperative variables other than operative time favors robotic cystectomy. Surgical outcomes are similar, and again the quality of life is almost equal in the robotic and the open cystectomy. Coming to the readmission rate after the open and radical robotic cystectomy, 30 days readmission, time for readmission, and readmission in length of stay, all are similar compare in both the modalities. Coming to cancer-specific mortality, again robotic and open are matching. Now the learning curve about the open cystectomy. This article says that minimum 10 cystectomy should be done by the resident, or he should do 10 surgery in a year to maintain the proficiency, so that he should have less than 10% rate of all over margin, and in 20% for the bulky disease, he should be performed to do standard PLND, and lymph node yield should be minimum of 10 to 40. About the cost, this study again compared the cost, and it concluded that robotic assisted radical cystectomy has a similar perioperative and survival outcome, but again at the higher cost. Now coming to recurrence, in the open radical cystectomy, operative sites, lymph node, bones, liver, lungs are the most common site of recurrence. When we compare open study and robotic study, other sites are comparable except peritoneal deposits. That is more common in the robotic. Again, one other unusual site of recurrence is the port metastasis, which only happens with the robotic radical cystectomy. The importance of this recurrence put patient into the stage 1 or 2 directly to stage 4 disease. Now, for issue with the robotic radical cystectomy is the feasibility, because most of surgeons all over the world more familiar with the open method, and the learning curve is slightly longer than the open surgery. Again, accessibility of robot is an issue everywhere, not available. About the contraindication, the patient who is not fit to give a robotic steep head position, 30-degree, and having lung complication, they cannot go with the robotic surgery. Again, port sites, unusual site of recurrence, and the cost is definitely, and sometime in unexpected situation, MIS may require to convert to the open approach. So what I want to say that radical cystectomy can be performed efficiently with all the techniques. Survival and quality of life is better with the orthotopic neobladder, whether it is extracorporeal or intracorporeal is better than the perioperative outcome. Again, except operative time, robotic assisted approach has distinct advantages in perioperative events and earlier late complications, but no difference in oncological outcome. Limiting factor, cost and availability. Yes, I agree with Dr. Girdhar. Time is changing, technology is advancing. Robotic radical cystectomy may become non-inferior to gold standard in future, but till then, open cystectomy will be the gold standard. Thank you.
Thank you, Dr. Mahendra, for a very clear message from your side. So we have two experts
Thank you.
who are absolutely well known in this field. First would be Professor Nitin Kekre sir. I think everyone knows him. So I would like him to present his expert comments for the talk.
Thank you very much, Ravi, for inviting me. I think it was congratulate both Dr. Bora and Dr. Paul for a very balanced presentation. Obviously, the robotic technique is a new and the literature would gather in time. But as of now, when we speak, we need to speak on what is the current evidence. And the Cochrane evidence, which is recently published, is very clear that the only advantage of robotic assisted radical cystectomy with intracorporeal diversion is a less blood transfusion and probably a 1 day less operative stay. And obviously, it will be naive to believe that any surgical technique will change the oncological outcome. The oncological outcome essentially is a function of the disease. What is the aggressiveness of the disease? What is the grade? What is the lymph node? That would decide the survival, not the way we, whether you operate laparoscopically, robotic or open. So naturally, the oncological outcome won't differ. But I think it is also important to consider the surgeon's comfort. And I don't think anybody would deny that there is a significant surgeon's comfort in a robotic way. And whether it will translate into more volume of cases, that's another thing. Another thing which is very worrying, for which we always must remember that not everything gets published. But there are some nice experimental studies which people have done, the peritoneal fluid analysis, the circulating blood cells, robotic cells, and found a very high percentage of malignant cells in the fluid. So that worries you, that there's definitely some problem as far as the spread of this malignant cell are concerned, whether it will translate into higher incidence of port metastasis, higher incidence of atypical metastasis has to be seen. Another factor which has not been highlighted is what is the difficulty of robotic surgery, because most of the robotic series which are reported are naive cases. What about previous operations? Previous surgical operations for any other? I think that makes it more complicated. And we don't have a mature data on that to say whether robotic surgery is the similar or will have more complications in patients who had previous intraabdominal surgery. Obesity also is a significant risk factor. So I think these are the things which we need to definitely keep in mind. And as far as I'm concerned, if tomorrow I am asked to choose a surgeon, I would rather choose a surgeon who is experienced in a high volume center rather than get influenced whether he operates robotically or laparoscopically. So I think that message has come into many trials, and I think I would still go by that it is important to have a high volume center. And when tomorrow somebody has a high volume robotic center, maybe. But till then, I think I would, and the cost is a very significant factor. That too in a country like India, we need to very strongly look at that. Should we force a poor man to pay another 1.5 to 2 lakhs rupees for when the same thing can be obtained for a...
Thank you.
Thank you, sir. Thank you for enlightening us. That was a very wonderful expression of the perspective. So we have second expert, Dr. Yuvraj. I think he would qualify as one of the high volume centers for robotic surgery. So let us hear from him his expert comments. Dr. Yuvraj, please.
Thank you, Ravi. Can you hear me?
Yes.
Yeah, thank you. I think the presentation was good. So that's how the evolution of robotic surgery in bladder surgery is going now. So as Dr. Kekre told us, I agree with him that, this is not the day where we can say that everybody should be undergoing a robotic radical cystectomy. Basically, it amounts to case selection. As he told, peer abdominal surgery not suitable for robotic surgery because of various lung conditions. So we need not do robotic surgery for those patients, but indicated patients. So I think, robotic surgery is the future, and already we are doing in many centers, including you, we are doing robotic surgery. We have seen the results, and although we have not done any randomized trials, so a few questions arises as, he told that, the local peritoneal meds and all those things. To a certain extent, what we are seeing in our institute is that of late we are practicing routine neoadjuvant chemotherapy. And with that, the peritoneal seedling and spillage, if we avoid, I think the only reason where we get peritoneal seedlings are, so when we have the spillage of the tumor from the bladder, when we are doing the apex of the prostate, one. Number two, if the patient has advanced disease in the lymph nodes, when we dissect lymph nodes and we rupture the lymph node, these are the two situations where we will come across peritoneal metastasis. However, in our series, almost we have done now 290 cases. Only one patient had peritoneal mets. So that patient also had lymph node positivity. I think these are technical issues rather than, and technical as well as disease issues. And if we are doing good volume surgeries, I think the benefit we can see from our own eyes in our patients. I think robotic surgery, whatever the presentation and the literature is going to support us in future. We have to wait for a couple of more years where all the centers, including many government hospitals, even private hospitals, including CMC, now has CMC Vellore has a robot, and the future will tell us whether it's true even in the government setup. Thank you so much.
Thank you, Dr. Yuvaraja. So I think the gist for this dilemma would be that yes, it is the volume which matters and not the particular technique. You have to master one way of doing a surgery, which could be the robotic open or laparoscopy, and then do it in a nice way. Whether you do open or robotic, it should have a similar outcome. So with that thought, let's move to another scenario, which we recently and which we very commonly encounter in our day-to-day practice. You have a 3 centimeter bladder tumor, which comes as T1 high grade. You do restage, and yet there is no tumor, so it's still a T1 high grade. So what is your best treatment offer for such patient? So we have two very enthusiastic speakers. Dr. Tarun Jindal is from Kolkata. He'll be speaking for radical cystectomy in such a scenario. And we have Dr. Ankur Mittal from AIMS Rishikesh. He will be speaking for intravesical therapies. So over to you, Dr. Jindal. Dr. Tarun?
Yeah, and just give me a second. I'll share my slides. There is a problem with the slideshow. Can I request the other speaker to start first? Give me a moment.
So while you set up, maybe Dr. Ankur, you can start with your presentation on intravesical therapies in such a situation.
So am I audible and my presentation visible?
Yes.
Okay. So at the outset, I would like to thank USI and UroOncology subsection for this opportunity. As we all are uro-oncologists, we always love to do radical cystectomies, but let me see and talk about intravesical therapies, the preferred approach in T1 high-grade lesions. So as we know, up to 20% of tumors at presentation are T1 G3, and if they are left untreated, 80% they may invade and advanced disease can present. As per EAU 2022, there is a strong recommendation to offer intravesical full dose BCG installation 1 to 3 years or discuss immediate radical cystectomy options to the patients. But again, if we discuss in detail, they have categorically submitted that the different treatment options for BCG unresponsiveness, late BCG relapse that is high grade, and also for low grade recurrences. So both the options exist, but which one to be offered, it is again set. So it's the same thing. They have we have AUA recommendation for the same any high risk T1 high grade disease. BCG is the modality of choice as of now, gold standard. We are not talking about the variant histology. The topic is T1 high grade, and that's why BCG is the original cancer immunotherapy. And as we all know that it functions via the activation of immune system and induction of inflammatory response. To summarize, the reduction in recurrence As BCG as intravesical therapy goes to 32%, progression decreased 27%. There is no superiority of BCG strain one over the other. Optimal induction 6 cycles, maintenance 1 to 3 cycles as per different guidelines. As we always talk about 1 year and 3 year maintenance therapy, we have EORTC, RCT, which have showed that there was a marked reduction in recurrence rate when we talk about 3-year maintenance over 1 year, but there were no difference in progression over survival, although there were 36% dropout in 3-year schedule. Main reason was treatment inefficacy. When we talk about BCG second cycle, basically in BCG failure cases, the progression and metastasis definitely increases. It is as less as 7% in the first course and as more as 30% in the third course progression rate, and similarly for metastasis. We have cases when we have contraindication of BCG, so we need to definitely look for other intravesical therapies what we have in our basket for BCG naive cases. And also there is a concern right now for global BCG shortage, and that's why we have so many researches which are going on from our group, and basically we are looking forward for the intravesical therapy option for BCG naive patients. So one thing is we have adjuvant HIVAC, the paper which was published in Journal of Urology in 2016 have shown that 20 milligram 50 ml for 2 sessions they have used, and the 2-year recurrence-free survival was better than BCG alone as inpatient, that is 82% versus 65%. Similarly, there are studies on neoadjuvant HIVAC therapy with mitomycin, and which have shown that they have used 80 milligram in 50 ml, and then TURBT was done 7 to 15 days later after installation, and 3-year cumulative incidence of recurrence was 15%. Let's come to the other intravesical therapy in BCG naive patient, gemcitabine alone. There is a trial for gemcitabine versus BCG, a randomized prospective trial published, and they have used 2 gram gemcitabine as a dose and have concluded that it is inferior to BCG for primary high-grade T1G3, as a recurrence rate was 44% as compared to 28% in BCG arm. So the solo agent gemcitabine, as per this study, was not preferable. Then certain combination therapies, this is again a breaking combination, which is gemcitabine docetaxel, GemDoce. And the studies which were published on GemDoce versus BCG, they have shown that the 2-year recurrence-free survival and overall survival is up to a tone of 80 to 85%, which is quite promising. Again, there are certain ongoing trials which are going in this BCG naive patient. So there is Sunrise-3 trial, which is an ongoing trial. They are doing a trial on TAR-200 plus sertolizumab and comparing with BCG in naive patients, and the completion date is around 27. And what does TAR-200 do? It is a device basically which is designed to prolong the intravesical drug delivery for gemcitabine. As we have already read that solo gemcitabine in naive patient is inferior result as compared to BCG. So there, I think there work going on. There is a trial, ongoing trial going on, GemDoce, prospective trial. And again, with the results of the retrospective outcome, the results are still due in 24. There is a trial going on, a non-inferiority bridge trial. They are comparing head-to-head GemDoce with intravesical BCG, and the endpoint is event-free survival. And then there is a trial which is going, it is a Potomac trial results where including 3 arms, BCG alone induction maintenance 2 years, BCG induction maintenance with durvalumab, and BCG induction and only with durvalumab. So basically, all other molecules that are coming up in a big way. The results are still awaited. But if we summarize the disease-free progression and recurrence-free progression as of now, as per current literature which is available, radical cystectomy, so all seems to be comparable except the solo agent gemcitabine in this BCG naive patient. So I think this is as per what literature we have. Other trials which are going on, we need to wait for the results. Now, what about BCG failure? So if we talk about BCG failure, we have a study on adjuvant HIVAC mitomycin. So they have, done a head-to-head trial in BCG failure cases, and they came to a conclusion there is no statistical difference in recurrence-free survival between these 2 arms with a median follow-up of 35 months. Then there is a trial on, again, a solo gemcitabine agent in refractory cases. So we have a Cochrane review on this, a systematic review, which have analyzed RCTs, those who have used gemcitabine as a solo agent in failure cases. And to our surprise, we can see that in BCG failure cases, gemcitabine is superior to another course of BCG or mitomycin. And they have concluded saying that it can be considered in refractory cases if cystectomy is contraindicated or refused. So I think the cystectomy is chipping inside in BCG failure cases, but not as such in BCG naive cases. Then this molecule combination gem-dosi is coming a big way. Pathophysiologists, I need to express that what gem does, it is an exfoliant, increases the penetration of dosi. And what dosi does, it inhibits microtubule disassembly, inhibiting mitosis. This is how they are working synergistically, and these trials, prospective, retrospective, coming way. And similarly, we have a gem-dosi study which has been published for BCG failure cases and have emphasized that recurrence survival are 65% and 52% respectively in both the arms. There is a trial using this Pembro with BCG, but unfortunately, this trial was closed with 9 patients due to COVID, and we don't. It's too early to comment upon any result, and maybe we will have further trials in BCG failure cases. This trial, I should specify, Legend trial, having quite promising results when the interim analysis. What they are using is EG70. They are using dual RIG1 agonist and IL-2 local gene therapy, which is non-viral gene therapy in patients with BCG failure. And what they have emphasized in interim results, that 83% of patients, they achieved complete response at 3 months. And if you see about the adverse effects, there are transient grade 1, grade 2, and well safe and efficacious, as they have the results have shown interim. Rest results, I think we will get by 26. I think we are not about the cost and availability will be a concern, but definitely it can be and have some promising results. So now to summarize, if we talk about BCG failure, whatever data we have as of now, right, we can see we have a significant difference between the disease-free recurrence and recurrence-free recurrence in radical cystectomy arm and the intravesical therapy arm, including BCG as the second line. But if we see that including BCG as second line, the other drugs which can be used are gem-dosi, gemcitabine, and maybe mitomycin hyvac. But yes, there is a significant difference. So I think I just want not to say it in a debate, but the take-home message which I need to specify that as per literature, if we talk about T1, G3, high-risk BCG naive patient, the gold standard still is BCG as per guidelines. But the single agent, if you are talking about HIVAC, mitomycin, have shown favorable response. Combination gem-dosi is again coming up with some results. Solo gemcitabine is inferior, but if we talk about BCG failure, here we gemcitabine alone or in combination can be used if cystectomy is contraindicated or refused, or BCG as a second line. Again, so I think with this, I conclude my talk, and thank you so much for your patience hearing, and I can ask the other speaker to tell it. Thank you.
Thank you, Ankur, for a wonderful talk and a good review of literature for to supplement your topic. So, is Dr. Tarun, are you ready? I think he is not being made co-host, and that's why he's not able to share his slides. So may I request the USI team to just make Dr. Tarun Jindal co-host?
Yeah, I believe I'm audible now.
Yes.
Thank you. Yeah, this was the problem then. Right.
So, Dr. Tarun, over to you.
Thank you.
Thank you.
So let me just start with the sharing my slides. And at the outset, let me thank the oncological section of USI for coordinating this amazing session. It has been very informative. So the topic for me to present today is, I do not know whether my slides are visible or not. Are they visible?
Yeah, they are visible. Just make it full screen.
Right. I'm trying that. I do not know what's the problem today. Let me see.
Maybe you can just continue. Yeah.
Yeah, I'll just continue with this. So Right. I believe now they're visible.
Yeah.
Yes.
Okay. So the topic is whether what if we offer radical cystectomy to patients who are T1 G3. Let me just go to the first slide. I don't know what's happening today. Right. So let's start. Around 30% of the patients which we treat by TURBT, we will find out that these are the patients who are suffering from a high-grade non-muscle invasive bladder cancer, that is a T1 G3 bladder cancer. We have to understand that at least 15% of these patients have a potentially fatal disease, and we need to aggressively treat these patients. The rates of progression to muscle invasion of this subset of patients varies to around 25% to 50%. So let's discuss if cystectomy stands as the correct treatment for T1 G3 non-muscle invasive bladder cancer. So what are the risk categorizations? So a high-risk bladder cancer is a T1 bladder cancer or a cancer associated with carcinoma in situ, or if it's a more than 3 centimeter tumor, or it's a multifocal tumor. The NCCN also categorizes certain very high-risk features if the cancers are associated with variant histologies, if there is presence of lymphovascular invasion, if there is prostatic urethra involvement, or if the tumors are BCG unresponsive. So let's see what the guidelines say. So if it's a BCG naive patient and he has a very high-risk feature, then cystectomy remains the treatment of choice and BCG remains the second treatment. But if the patient does not have very high-risk features, so it's a high-risk case, but not associated with very high-risk features, then both the options, BCG as well as cystectomy, can be offered to these patients. But if the patient is BCG unresponsive or BCG intolerant, then cystectomy remains the preferred choice. So let's come to the statistics. So 30% of all T1 G3 non-muscle invasive bladder cancers are associated with very high-risk features. So upfront radical cystectomy as per the NCCN guidelines must be offered to these patients. The other 30% of T1 G3 are associated with high-risk features. So upfront radical cystectomy can be offered to these patients. And T1 G3 itself indicate a high-risk disease. So again, going by the guidelines, upfront radical cystectomy can be offered to these patients. Now let's see if we have data by which we can change this can to must. So what are the advantages if we offer all patients of T1 G3 primary cystectomy? First of all, it allows us to have a correct pathological staging of the tumor. I'm sure everybody knows this, that if we perform a radical cystectomy to all comers of T1 G3, at least 25 to 30, and some papers say up to 50% of these T1 G3 tumors will be upstaged at radical cystectomy. It also allows us to do a good lymph node dissection, and we also know the lymph nodal involvement and accurate staging of the patient. Rather than a clinical staging, we have a pathological staging available to us, which can help us in tailoring the treatment and also predicting the survival outcome of the patient. Comparison was made if we follow up the patients who primarily had a muscle invasive bladder cancer versus the patients who had a non-muscle invasive bladder cancer high grade, which progressed to a muscle invasive bladder cancer. It was found that everything in the patients who have progressed from non-muscle invasive to muscle invasive is poor. That is, the 10-year recurrence-free survival is poor, the overall survival is very poor, and the disease-specific survival is also poor if the patient progresses from non-muscle invasive bladder cancer rather than the patients who primarily present with muscle invasive bladder cancer. So our delay in offering radical cystectomy to these patients is actually detrimental. This is a level 1 evidence, a systematic review which was published in 2020, and 1,500 odd patients were included in this particular study, in this analysis, and the outcomes were compared with the patients who had a BCG and deferred cystectomy versus patients who had a primary cystectomy. And it was found that the 5 and 10-year cancer-specific survival was much better if the patients were offered an early cystectomy as compared to the patients who were offered a deferred cystectomy. Other advantages, technical advantages, you can do a better nerve sparing, I believe, if the patient has not had recurrent TURBTs, recurrent BCG installations, fibrosis, and inflammation. So the technical difficulties in primary cystectomy are less, so that the functional outcomes can also be assured. Again, the feasibility of a neobladder reconstruction may be slightly better if you're offering primary cystectomy to these patients, because these patients are fitter, the creatinines are better, the risk of late recurrences is greatly reduced by the virtue of offering them primary RC, and we can also decrease the extensive follow-up required if we are using intravesical agents in these patients. With the introduction of enhanced recovery after surgery protocols, the length of hospital stays have actually reduced. And now we can say that as compared to the conventional surgeries, we are following the ERAS protocol, the average hospital stay has come down by nearly a week. We can also offer radical cystectomies by minimally invasive methods like robotics or laparoscopy, which decreases the scar morbidity, the pain, and the recovery is also hastened. Again, the patients who are upstaged during radical cystectomy from a non-muscle invasive to a T2 setting, they can actually avoid chemotherapy. So this would happen in at least around 40%. So what is the issue with the BCG? So in around 30 to 40% of these patients, we do not actually know what is the correct pathological stage. So we are basically mistreating a T2 disease as a T1 disease, and we are bound to fail. In the other subset, we have already discussed that around 30% of these patients will have a disease progression. So 60% to 80% of the spectrum is gone. Only 20% of the patients are the patients who would be correctly treated by BCG or any other intravesical therapy. So my question is it the right time to change the whole concept and say that rather than reserving cystectomy for a limited subset of patients of non-muscle invasive bladder cancers, we should actually reserve BCG or intravesical therapy for a selective subset of patients who have a non-muscle invasive bladder cancer T1, G3. The other effects with BCG are, or with any intravesical therapy for that matter, is the quality of life, because there are significant patients who have local symptoms. They are not able to sleep properly because they have to pee every hour in the night. There are also episodes of severe BCG toxicity, systemic BCGnosis, which can also happen, which require prolonged treatment. And if the SWOG analysis is considered, only 16% of the patients are able to complete a BCG maintenance because of the extensive side effects. So we are basically stopping the treatment in between. So whenever I talk about BCG, this is a good picture which I always show to my patients, that this is what the life becomes. So you basically have a sword hanging on your head. One wrong judgment and this sword is going to kill you. Other issues, again, with intravesical therapies, including BCG and other therapies, is that you require repeated installations. That means repeated cost, repeated hospitalizations, repeated visits to the hospital, OPD charges. And this is a cost-sensitive population which we are talking about. Repeated episodes of dysuриas, UTIs, multiple courses of antibiotics. You require multiple scopies, and eventually the person who had a bladder cancer, whose life was already worse because of that, ends up with a urethral injury, urethral stenosis, and stricture, and now he needs treatment for that also. Multiple TURBTs, multiple biopsies, loss of functional capacity of the patient, fibrosis of bladder, risk of secondary complications. So are we actually showing them the correct path? So do you want a longer life with less quality, or vice versa remains the most? We are always skeptical that radical cystectomy basically makes your life much more, the quality goes down dramatically. But if you consider this analysis, so this has categorically found upon a radical cystectomy does come down in the initial 3 months, but it eventually improves and it reaches the baseline within 6 to 12 months. But the same doesn't happen with the patients who have been on BCG. And a very interesting observation is that once these patients were asked whether you regret radical cystectomy or you regret being on BCG, people regretted more for being on BCG rather than being on radical cystectomy. So this is an anecdote which I had basically taken out from a European urology editorial. And this is from Barusi, who's a very well-known person in bladder cancer management. So he has made a very good observation. So we frequently hear during UroOncological meetings that we do not have enough data to support radical treatment to our patients who have a T1 high-grade bladder cancer, and we need further studies. Is this completely true, or the urologist is trying to preserve bladders even in risky situations? Is this approach justified? I believe this is not. So to conclude, I believe this is the time when we become more pragmatic in managing a T1 G3 non-muscle invasive bladder cancer. It's time to be extremely selective about the patients in whom we are offering BCG or intravesical therapy, and radical cystectomy should actually be considered as the gold standard in majority of the patients. Thank you so much for this opportunity, and my apologies for the technical glitches which happened. I do not know why they happened. Thank you so much.
Thank you, Tarun, for a nice presentation and a very clear-cut overview of how to manage T1 high-grade bladder cancer. So we have two great teachers from two eminent institutes of the country to present the expert comments. Professor S.K. Singh sir from PGI Chandigarh and Dr. Professor Anish Srivastava sir from SGPGI Lucknow. So over to you, Singh sir.
I congratulate both the speakers who have put up their point very strongly. And I think Dr. Jindal has put it very forcibly. I can see when the patient of T1 with high grade has risk-associated features, certainly one should counsel the patient for radical cystectomy. But at the same time, the surgery again is a really fear for the patient. When you say the patient, but that your disease has not gone beyond the lamina propria, many of them may think of preserving their bladder as well as the sexual function. So it's a real dilemma. I think as an expert, I would like to say the T1 high grade treatment of the T1 high grade is a real dilemma. So what are the guidelines that you have to follow? Because maybe in the future, still we don't know who is going to progress, whose prognosis is going to be bad. So that is a real dilemma. If the patient has only one tumor and that can be completely resected, has T1 high grade, certainly you can put him on intravesical therapy because outcome is going to be good. But same time, you must emphasize to the patient that he has to be under follow-up, because anytime the things can go worse. So you have to counsel the patient, you have to take consent when you are putting the patient on intravesical therapy. But same time, when you put out the patient on radical cystectomy and diversion, really, this is a most major surgery, urology. You have to have that shared decision with the patient. Most of the time, I have seen patients are reluctant to undergo cystectomy, even if the patient has a high risk factor. But same time, you have to say life is important than quality. If you are not living, then how can you think of a quality of life? And again, quality of life also again has to be thought of, as Dr. Jindal has told, other than life. So with this philosophy, I will say every time the decision has to be shared one, you have to give the data to the patient, but same time, you have to a real guide to the patient. Patient gets confused, usually they leave it to you, what is to be done to the patient. So I will say, let us hope molecular and genetic marker may come in the future, which will certainly say which patients are going to be put for intravesical therapy and who are the patients with high risk factor will get benefit of radical cystectomy.
Thank you.
Dr. Srivastava.
Dr. Anish, sir? Yes, sir.
Am I audible?
Yes, sir. Yes.
Okay. Thanks to you and to the USI for the opportunity. And I think Professor S.K. Singh has, in brief, made very apt comments, and I fully agree with whatever he says. But we need to understand one thing, that whatever Ankur has stressed in his talk about the different kind of intravesical therapies coming up. I mean, we have now answers for the BCG relapses, the other resistance and other things. So I still feel, as Dr. S.K. Singh also reiterated, that there is a fear of major surgery. It's a super major surgery if we were to offer upfront. And then when we have options, I think most of us would like to go for the intravesical therapy, because in view of the complications associated and the fact that there are choices. And I think the final answer would someday lie only in trying to identify or predict that who are the patients which are not good for starting the, say, BCG, which is most popular or other thing. In our institute, we have done trial with the X1CC codone, which is a base excision repair protein. And we found that those patients who express this, they have a, I mean, they don't have a as good response to BCG as compared to the other patients. I think molecular and genetic markers probably at one time may give some answers. Thank you.
Thank you. Thank you, sir. Thank you for those enlightening comments from both of you. So we are already running late. So let's move to the next topic, which is a very common dilemma you have in your MDT clinics, that a patient given a neoadjuvant chemotherapy and is completely responded to it. Now, what to do in such patients? And then as a presenter, we would have Dr. Vedang Murthy. He also doesn't require an introduction. He is a radiation oncologist from TMH Mumbai. And he would be speaking for either preservation or chemoradiotherapy, that is no RC. And followed by Dr. Sanjay Adla, who would be speaking for radical cystectomy. Over to Dr. Vedang.
Thank you, Ravi. Everything is okay here on my end?
Yes, clear.
All right. Thank you so much. It's a great pleasure to be here, honor to be here rather. And I am the odd guy here. I among a very enthusiastic and very experienced bunch of surgeons who love to do cystectomies, but I'll put a different point of view to this very common, well, not very common, but often seen situation in our clinics of post NACT complete responders in bladder cancer. Before I jump in, let me start with a story. There is an organ X which is functionally important. It's the gold standard for that treatment is to remove the organ X. But obviously the patients don't like removing that organ or losing that organ. So some fine gentlemen with foresight, they proposed giving 2 cycles of neoadjuvant chemotherapy and checking the function and response. And those who had a good response and good function, radiotherapy was given to these patients. And those with a poor response or function, they had their organs removed. As a result, about 2/3 of the patients saved this vital organ of theirs, and which is the standard of care today. And this is called bioselection. And many of you may not place this, but this is the famous NEJM trial of Veterans Affairs in larynx cancer. And we actually have to see if the same bioselection process can be replicated, or I can make a point that it can be suitable for bladder cancer as well. So NACT improves outcomes after surgery, so it should be given. We know it from the classical SWOG trial and the meta-analysis, 5% improvement in survival. But what many of you may not have realized or may not have known is NACT also improves outcomes after before radiotherapy. So the data comes from an MRC trial from the UK, where local treatment was given, either RT or surgery, about 400 patients each, and all of them had CMV as neoadjuvant chemotherapy. And you can see here, not only before surgery, but even before radiotherapy, NACT improved outcomes. Now, this is from the UK. Let us see our own data. This is over 100 patients treated at TM's Tata Memorial Hospital. These are long-term outcomes, 5 years median follow-up. The only 2 factors, and these are all CTRT patients, about 30% had NACT. The only 2 factors that showed advantage on multivariate analysis were younger age and neoadjuvant chemotherapy. It is really an important treatment. Now, if we give neoadjuvant chemotherapy to about 100 patients, about 5 to 10 will have progressive disease, and that is that. About 60% have stable disease or partial response, and they undergo surgery or radiotherapy. You can see in the middle of the chart here. But we are talking about 1/3 of the patients who have a complete response as judged by a cystoscopy, CT scan, maybe even a TURBT. And 2 things can be done: either do nothing or give some local treatment. And local treatment could be surgery that Dr. Sanjay Adla will tell us all about a little later. or we can give radiation. Now, let me show you what happens when we do nothing after after a CR. The best data was published a couple of years ago. This is from the US. 148 patients, all of them had NACT, and these patients had a CR as determined by imaging and TURBT cytology, and they were actually kept on surveillance, and median follow-up was 55 months. About half of them had a recurrence in bladder. Many of them had muscle invasive, and 10% actually developed metastasis. And interestingly, all those who developed metastasis, about 3/4 had a local recurrence first. So clearly there is something happening in the bladder, even when there is apparent CR, because imaging, cytology, TURBT, all can underestimate the presence of microscopic disease. So if we do a cystectomy, Dr. Adla will tell us it reduces local recurrence and avoids the uncertainty with surveillance and HPR, etc. But I think for that advantage, we overtreat nearly 60 to 70% of the patients, and these are all with a good CR, clinico-radiological CR. And the overtreatment is not only simple overtreatment; it's a complicated overtreatment with a lot of toxicity, a difficult surgery, as we have just seen in all the last few talks, and unnecessarily losing a vital organ. And I don't have to tell this audience what the difficulties are with cystectomy in terms of toxicity and even mortality. And this is where radiotherapy provides a great opportunity. I'll tell you why. These are biologically selected patients for being good responders to chemo already. So biological selection works. It does work. There is microscopic disease, hopefully, and the doses actually can be reduced or tailored. And even from what standard doses are given, a reduced dose can be considered. A native functional bladder is always preferable even to a neobladder. Radiotherapy works best when there is least gross disease. And I will just show you in the next slide why TURBT is such an important component of bladder preservation. And clearly there is data that there is less toxicity with radiation than with surgery. So I was just thinking about this, and maybe if you look at the TURBT data, CR on TURBT actually predicts overall survival. This is data from Germany. You can see with an R0 resection, a complete TURBT, how the overall survival falls if there's R1 or R2 resection. So less, this is after all bladder preservation, and less disease there is, better the outcomes. Now, as far as toxicity concerned, I'm not referring you to any data from the West. This is published. Now, we have over 200 patients treated with bladder preservation. Really speaking, grade 3 toxicity is less than 5%. And so we really don't char and burn the bladder as many think. It is a good treatment when done properly in the right hands. And 5% grade 3 toxicity is not at all too much, certainly not in relation to surgery. So it is a good treatment with good quality of life. Now, in the end, I'd like to show you, can we choose to do nothing smartly? Now, this comes from a very recent data from called the Retain Bladder. This is a phase 2 single-arm trial, 71 patients. All of them got dose-dense MVAC, and they also got tested for mutations in ATM, ERCC2, FANC-C, and RB1. So these were chosen because these mutations are associated with path-CR and better survival. And those who had a CR and mutation positive, they were supposed to do well. And 26 such patients were all observed, and only 7 of them needed cystectomy or radiotherapy, and 90% were metastasis free. Again, 10% had metastasis, but this is the way probably to go in the future. But this is again not routine practice. Finally, my point of view on CR after NACT, I think fit patients should be encouraged for NACT. before local treatment. It really helps with the outcomes. And probably India is also no different from the global NACT uptake of only 15 to 20% patients actually undergoing neoadjuvant, maybe slightly more. Clinical CR is not equal to path CR. We are likely to miss some disease with the best of imaging and cystoscopy. Patients with CR should be strongly encouraged for local treatment. Surveillance is not recommended routinely. Cystectomy may be over-treatment in a large majority of the patients. There is clearly a need to do something that is less morbid and less complicated. Radiotherapy provides the best middle path, both logically, as I have showed, and biologically. So treat the bladder, but don't remove it. Thank you.
Thank you, Dr. Vedang, for a very enriching presentation, I would say. So, Dr. Sanjay Adlab, he also is a very great debater. He won't require an introduction. So, over to Dr. Sanjay for your talk on doing radical cystectomy for such situation.
Thank you very much, Ravi, and I'm thankful to USI for giving me this opportunity. I'm just trying to find my presentation, which is here. Okay, so Professor Vedang has laid out the turf for me to give a evidence for why I believe cystectomy is better compared to radiotherapy. So this is quite a unique scenario. Post NAC MIBC is radical cystectomy the standard of care? And how do we assess a patient post NAC? And it's the same problem. Even post radiotherapy, we tend to use the same one, which is a urine cytology, and quite often in India, an ultrasound scan to assess the response following radical radiotherapy. But here I'm using post NAC, the standard, which is urine cytology, rigid cystoscopy, and biopsy. Not just rigid cystoscopy and biopsy, and imaging, whether it's CT, MRI, or PET, and there isn't any evidence of disease. And this is what were categorized as clinically complete response. So just answering the first question, just driving home the point that Vedang has mentioned. So this was, I'm going to just show you two slides of this one. So this one was similar to what Vedang has shown. So these were patients who are post neoadjuvant chemotherapy, 48 patients who had clinically T0 response. And they were offered radical cystectomy, as was the standard of care, but these patients refused to have radical cystectomy. So they were followed up with urine cytology, with rigid cystoscopy and biopsy, as well as imaging. So that one was 41 patients. And what you see is that 19 of them recurred. That's one. And second, they seem to recur very early within the first 6 months. So what you categorize as clinically T0 actually isn't T0, especially if you take the example of this one, in that they do tend to have, I wouldn't say the recurrence, because 6 months is a too short a time. So I would say that this is persistence of the tumor, and these patients do need something done. So these were post neoadjuvant clinical T0. Okay, that's what. So around 50% of the patients do tend to, around 46% of the patients do tend to have tumor when they are assessed or when they are followed up. This one, you can recognize quite a few names, Ashish Kamath and Jay Shaw. Is that this is probably the largest number of 157 patients, wherein what they did is these were patients who had radical TURBT. So they were T0. So radical TURBT followed by another TURBT to make sure that there was no tumor on the second TURBT, or patients who have had neoadjuvant chemotherapy who had again clinically T0. 157 patients, but all of them ended up having radical cystectomy. And what they found is the complete response rate, when you talk of complete response rate post neoadjuvant chemotherapy. So these were T0 patients who went on to have radical cystectomy. There was still persistent tumor in almost 46% of the patients. So just because they are negative doesn't mean that that's what they are. When you take their bladders out, there is persistent disease. And then the second is, if you see the advanced disease, which is non-organ confined or lymph node positive disease, a quarter of these patients had it. So just because they have had CT0 doesn't mean that they have CT0. They do need something done. And when you take, they were followed up further on. So these were patients who were CT0, who underwent radical cystectomy, and then they were followed up. And when you look at them, still there were deaths. 21% of the patients died of bladder cancer. So the first thing that we need to note is we are not, as JK sir has mentioned, they need to be alive, or Singh sir has mentioned, they need to be alive to be having a quality of life. In spite of having a CT0, having their bladder taken out, 21% of the patients still die. Okay, so this is quite a lethal disease and we need to take note of that. So complete response post NAC, there is a recurrence, generally tends to happen in the first 6 months. Post in patients who have just had a TURBT without neoadjuvant chemotherapy, there is a 64% chance that they will have residual disease when you take their bladders out. Post neoadjuvant chemotherapy, there is a 46% chance that they would have residual tumor when you take the bladders out. 25% of these patients do have locally advanced bladder tumor, and 13% have lymph node metastasis. So that's what we are talking of, either overall CT0 or post NAC CT0. How do we treat these patients? So rather than showing evidence contrary to what Vedant has shown, I've just gone to EAU guidelines. When they're mentioning that there is a strong recommendation for both TMT as well as radical cystectomy, that's what it means, in that both of them are a valid option. So I'm not going to counter Vedant by saying that TMT is not appropriate. TMT is appropriate, but the question is, when you look at, again, I'm just showing the evidence to say that when you look at overall series wise, they are similar. The outcomes are similar when you look at radical cystectomy, large series compared to TMT, large series. The overall, they seem to be effective, but the question is not that. The question is, where does TMT work? I'm not going to say radiotherapy doesn't work. Otherwise, all these radiation oncologists do their job. So there is a role for TMT, but where does it work? I'm going to quote the Massachusetts General. They have got the largest experience of TMT in the world. And they published this 30-year series. So the first one is the first 10 years, second 10 years, and then the last one over 8 years. What you see is, following chemoradiotherapy, they used to have complete response of around 66% in the initial part, improved to 81%, improved further to 88%. You can say that they've got better radiotherapy machines. Same when you look at the disease-specific survival from 60 to 64 to 84. But actually the difference is in this. When you look at the early series, there were T3A, 40% of the patients were T3A, 7% were T3B. When they came to the next one, the percentage of T3A decreased. And when you look at the latest series, so the center that has the largest experience of TMT experience in the world, they don't tend to offer TMT for patients, T3A and T3B. They tend to go for only the T2 patients, solitary lesion patients. So that's what they are. So TMT works in patients who have got minimal disease, who have got organ confined disease. And that's what was said in this one. If you see who are the ideal patients, T2, no hydronephrosis, no CIS, visibly complete TURBT, unifocal tumor. And then you have to just think, how often do we find that in our patients, especially in India? And then you start going to less ideal, contraindication, T3B, T4A, absolute contraindication, anybody with tumor-related hydronephrosis. Okay, so TMT does work, but TMT, is it appropriate for India? Firstly, the stage of presentation, we don't tend to have just T2 single lesions. Secondly, the cost implication, which I'm going to highlight. And the biggest concern in India is of the compliance. So when you look at the series that was recently published in 2018 from Delhi, you look at the percentage of patients who have got T3 and T4. These were pathological, I do understand that, but 65% of the patients had non-organ confined bladder tumor. And this is at a big center doing large numbers of radical cystectomy. So 65% of the radical cystectomy patients do need radical cystectomy. They are not appropriate for TMT. The second one, cost implication. It always sounds nice at the beginning, saying that in the first 30 days, they are almost equivalent. This is a US study, but you say that, oh, actually it is cheaper. Going for TMT is cheaper. It isn't. By the time they go to 6 months with all the rigid cystoscopies, all the images, it almost doubles. So when you look at the cost implications for India, it is more expensive compared to doing the radical cystectomy. The third one, the biggest of the concerns, these patients think that they are cured of their cancer. They do not want to come for follow-up. There is very good evidence for neoadjuvant chemotherapy, debulking surgery in ovarian cancer. But when they looked at 182 patients, this is ovarian cancer, they looked at the deviation. Almost 50% of the patients did not follow the protocol either with respect to the surgery, neoadjuvant chemotherapy, or post-adjuvant or post-surgery adjuvant chemotherapy. And that is the biggest concern with offering TMT in India. So post-NAC MIBC, radical cystectomy is the standard of care for India. Thank you very much.
Thank you. Thank you, Sanjay. I think both are fantastic debaters, and they tend to align you to one side or the other. So with that, let's have our expert comments from Dr. Sudhir Rawal. Again, he doesn't require any introduction, and Professor Santosh Kumar from CMC Vellore. So Dr. Rawal, sir.
Thank you, Ravi, and thank you, USI, for giving me this opportunity. In debate, I can say, as you can't beat Bajaj, you can't beat Sanjay Adala. So he has been a very good debater in putting his point to a extent that you get convinced with his all the data and all. And I agree, for India, things are different. But the point which Vedang has put, they actually do happen in practice, and 30% of our patients who go for NACT, actually they do not come for cystectomy, despite of, especially they have good response. And in many of them they fail, and some of them they actually do not fail. And there are data from GUSCO 2021, which Vedang has already shown that with gene and all coming in the way, in future, probably we will be more wiser when we'll be choosing these patients differently. But as on today, if the patient has got complete response after NACT, in my practice and in India, we better to offer surgery, but many of them, they may not agree. That's a different thing, but the standard of care is the better to offer surgery, because a subset of patient, as it has been shown by Sanjay also, they actually have even lymph node metastasis. You just cannot predict. Problem is that you can go ahead with radiotherapy, but you cannot predict which patients is actually having what type of disease, which will actually fail in future very rapidly. And actually surgery will give you two things. One is very good local control, and secondly, the information about the lymph node status and T stage of the disease. Thank you.
Thank you, sir.
Okay. Thank you, Dr. Sudhir. Now, after Dr. Vedang, Dr. Adala, and Dr. Sudhir has spoken, there is nothing much to speak on the subject. So they are good narrators, they have extensive knowledge, clinical practice for 20 years, and maybe more than 1,000 patients on bladder cancer, which they have the personal experience. So the few things that I want to point is a little different from what they have spoken. PCC is a radiosensitive tumor. Surgically, you can remove it. It also responds to chemotherapy. So properly used, all the three modalities will be giving the best results. The things that I want to comment on are on the NACT, the use. There's study showing that over the last decade, we have just improved from using it in 10% to just over 20 to 30%. So in your own center, it's very important for everybody to look at how much NACT they are giving. And if I think they're reaching 30%, like Dr. Sudhir said, I'm very happy. At least we have reached that world standard, where in India also we are offering it adequately. But if it is less, if you're really around 10% or less than that, I think it is time for all of us to gear up to the literature that is available. Now, response to NACT has been great. Dose dense MVAC has been the standard of care, and about 30% PT0 we have achieved. Now, the Pure One trial showed around 42% PT0. So there are many interesting drugs, IO agents, and combination of IO and cisplatin agents, which will probably change the scene in the near future. Oncology is changing too fast, and I think every year we have something happening. Third thing is about RT. That For a correct, carefully selected patient, I think we are under using RT for whatever reason. And for a correctly chosen patient, I think RT and surgery are about the same. So there is no need to say. One place where I think RT has again never been used or very few being used, I know Dr. Vedang and it was not having enough patients, and our own center also chipped in to help in the trial where they would give for positive or T3 and N+ patients adjuvant RT. Now that's again something which has not been tested and there's no evidence for it. So I do hope that RT will play a bigger role even in transitional cell cancer than in other cancers. Again, imaging is a small thing I want to touch on. We haven't been using MRI as we are not very experts in reading MRI, but I think in the post response, CT may not be a very great investigation and MRI may have more value post NACT. With those comments, I think I stop, Ravi.
Thank you, Dr. Santosh, for bringing up very important points which are pertaining to this aspect of management. Thank you very much. So with that, we move on to our last session, which is on my best treatment offer for managing a non-muscle bladder cancer with respect to bladder resection, because now you have various techniques of resection. So we have en-bloc resection of bladder tumor, which will be done by Dr. Vamsi P from Hyderabad. This would be followed by a talk by Dr. Himanshu Pandey on standard TURBT. So over to Dr. Vamsi. Dr. Vamsi?
Yes, sir.
Yeah.
First of all, thank you for giving me this opportunity to present this topic at this prestigious inaugural USI UroOncology subsection. Thank you, Dr. Ravi, and the subsection members, conveners. So I'll start my presentation. So there are various, before going to the different methods we use for en-bloc resection, different methods have been described. Basic scissors dissection has also been described, monopolar energy, bipolar energy, holmium, all kinds of lasers, KTP, 2 micron, thulium mag, and now even thulium fiber. So all of these energies, like what we discussed for an enucleation of prostate, the energy is not as relevant as anatomy. So coming to the schematic diagram, we all know what is an en-bloc resection. Just to brush what it is, here the tumor is being removed along with a normal tissue. This is what is an oncological principle. Any oncological surgery, we ensure we are not breaching the tumor. So if we apply the same here in endoscopic removal of the non-muscle invasive tumors, so the logic seems to be right in removing the tumor en-bloc rather than in piecemeal. So what is the evidence? So to start with, there are a few papers. One from our own place, Dr. Anil Mandani et al. He presented his results on using monopolar, the Maud loop. He physically pressed the loop, his group, to a 45 degrees upfront angle and used this as a monopolar way to en-bloc, do the en-bloc resection. So in his study, he compared the conventional TURBT with the monopolar en-bloc group, and he found the vision was clear due to better hemostasis, and most of the patients with the en-bloc resection had better detrusor muscle than compared to the control arm where the piecemeal resection was done. So it was effectively done safely with well-controlled resection and clear vision. So this is the monopolar resection group. Second is Xisheng et al. Is a Chinese paper published in Journal of Endourology in 2010. So they compared the efficacy of conventional monopolar, plasma kinetic, and holmium laser resection of the tumor. It is en-bloc resection by the plasma kinetic and holmium laser. So there was no difference in operative duration among these three groups. but they noted that the PK TURBT and whole MEM TURBT had less intraoperative and postoperative complications, including the operator nerve jerk. We all know why it happens in the monopolar group, and bladder perforation as well as bleeding and postoperative bladder irritation. So apart from this, there is no difference among the three groups in transfusion rate and occurrence of erythroid stricture. So now we know that definitely the operator jerk, despite using bipolar, sometimes it can happen. 25% of patients who undergo bipolar TURP also can face operator jerk. So there are a few meta-analysis. So this is done by Changlong Lee and published in the Lasers Medical Science Journal in 2020. The effect of whole MEM laser resection versus standard transurethral resection in NMABC. It's a meta-analysis. So what they found was totally they compared 9 studies, and the whole MEM laser en bloc resection reduced the time to catheterization and hospitalization and rate of recurrence. They found even the rate of recurrence at 2 years of follow-up to be better as compared to the piecemeal resection, what is standard. So as obviously operator nerve reflux is less commonly seen, and bladder perforation and bladder irritation were less compared to the standard TURBT. So one more meta-analysis where Mr. Alame et al., who did this recent publication in the same journal in 2022, they compared various types of laser in the treatment of non-invasive bladder cancer. So totally they studied various articles published in among different platforms, and 11 studies were studied, and among which 626 patients underwent laser en bloc resection and 742 patients underwent routine TURBT. And they also found the tumor recurrence, the duration of operation, and hospitalization and catheterization in laser therapy were significantly lower than the conventional TURBT group. So in addition, the incidence of complication was lower in patients treated with laser. So the operator jerk and bladder perforation and postoperative need for irrigation were significantly higher in patients with TURBT. Only in one patient, the postoperative erythroid stricture aspect, they could not find any difference between the two groups. So what does the EU consensus statement 2020 say about this concept? So this is done by a group of Europeans, most of them we all know, Mr. Dr. Thomas Herman. So they discussed 10 RCTs, and then they found there is a significantly shorter irrigation time post ERBT and lower rate of bladder perforation, and both and clearly there is evidence for these two, and there is no difference in recurrence rates at 1 year, 2 years, and 3 years follow-up. All were very low evidence. So the recurrence which was presented in earlier metastasis were not significant, and total of 99 statements were developed with consensus. And a summary is the en bloc resection should be considered always for treating non-muscle invasive bladder cancer, and should be considered feasible even for bladder tumors larger than 3 centimeters. And number and location of bladder tumors should not be the limiting factors to perform ERBT. So there should be a minimum circumferential margin of 5 mm from any visible tumor, and any additional biopsy should not be performed routinely from the tumor edge if ERBT specimen is properly taken. So this is the take from the EU consensus statement. And what does the European guidelines say in latest guidelines? So en bloc resection using a monopolar or bipolar current or a thulium YAG or homimag laser is feasible in selected exophytic tumors. It provides high quality resected specimens with the presence of detrusor muscle in 96 to 100% of cases. Even some studies are suggesting is the relook TURBT we routinely perform after a monopolar or a conventional TURBT, is it necessary? They raised a question because of the better quality of the specimen. So in the guidelines, they said perform en bloc resection or resection in fractions. So there is no clear-cut evidence. They were giving en bloc in the beginning. We don't know what will happen in the next year guidelines. For any tumor which has an exophytic part of the tumor with an underlying bladder wall and edges of the resection area. This is strong evidence that is coming up in EUA 22 guidelines to do a routine en bloc resection if feasible. So what is the summary of all these studies, the advantages? So whenever there is a difficulty to do like a lateral wall, there is operatic jerk. There is a perimeatal zone, we want to scar the meatus. and there is a dome where the perforation chances are high and we might lead to end up in intraperitoneal perforations. Better to do en bloc whenever it is possible. And overall, the chance of operative jerk and perforations are lower when we do an en bloc. And the completion of the excision of tumor is better in en bloc because we are going from a normal virgin mucosa entering into a crater, and then the plane is very good. And then only at the stalk of the tumor, if there is a stalk, that we have to just dissect it off from the deeper aspect. So the completion of tumor, as we have seen in the first schematic diameter, is better as compared to a piecemeal dissection. And the main advantage, what we theoretically perceive and which we should stress upon, is a less chances of tumor dispersal. Tumor cell dispersal, because we are not breaching the tumor anywhere, we are taking it in toto, and the chances of recurrence are theoretically less, but we don't have any evidence to say about this aspect. And obviously the hemostasis is better. We are not cutting the tumor. We don't need to seal the blood vessels as soon as sometimes we find a very vascular aggressive looking tumor, and doing a TURBT for a large vascular aggressive tumor might be very stressful even for the experienced surgeon. So here we are not touching the tumor. We are going from a normal mucosa and entering the plane, very good plane between the mucosa and the muscle. And because of the high precision of lasers, the chance of perforation are very less. We can dissect the planes very easily. And better coagulation of lasers have improved this hemostasis, and the drop in hemoglobin, the need of irrigation, need of catheter. Sometimes even small tumors we can send like an office-based fulguration. We are sending with en bloc tumors nowadays. And better histopathological examination. The specimen, smaller tumors can be marked with ink at the base so that the pathologist can find where the tumor is penetrating into the deep muscle. And there is because of the more precision with laser, if you want to do with laser, the lesser thermal damage and the better preservation of the pathology. So these are all the advantages, and some theoretical aspects, some large tumors. One study has found, which I did not mention, the chance of TR syndrome, which can happen in a large TURBT, or can be prevented. So with this, I'll show one limitation also. Now I don't have any data how to deal with a larger tumor, though studies are suggesting large tumors also can be done with this technique. So some people suggest dividing the tumor into 2 or 3 pieces and then dealing with them, so removing them with basket or forceps. What we have been practicing last few years, like some 8 to 10 years, we are morcellating larger tumors, and we are taking a separate deep muscle biopsy for a better histopathological presentation. We do this procedure because even in prostate, when we morcellate, there is no distortion of any histopathology. So the same analogy, we are doing morcellation for the bladder tumors. Until now, there is no histopathological distortion, or the pathologist could not find whether there is a, even in the specimen we mark as a tumor and the specimen B as deep muscle, there is no difficulty by the pathologist saying the morcellated specimen is not adequate for histology, or there is a distortion in the anatomy. It is clearly seen in a morcellation specimen, but we don't have evidence to say morcellation is appropriate, but it is only a single surgeon's experience or a team of surgeons' experience. This is one limitation I want to present. So I want to just show one or two videos if time permits.
Vamshi, for want of time, I know you are an excellent surgeon, and you, as your video, for want of time, I think we'll skip this video. You made your point very well. Thank you.
Yes.
So let's move on to Dr. Himanshu Pandey. He is from TMH Varanasi. And I think in a training institute, we are yet to be there with complete en bloc resection. So Himanshu, your comments on standard TURBT.
Good evening, sir. Sir, I'll be able to share my screen only when this.
Yeah.
I'm sorry.
Yeah, thank you, Vamshi. Thank you.
So, good evening, sir. Sir, are my slides are visible and am I audible?
Yes, yes. Just make it full screen, though.
Okay. So, to start with, a very good evening to all. And at the outset, I would like to thank USI UroOncology subsection and organizers for providing me the opportunity to speak in front of the stalwarts of the UroOncology. Actually, when I was asked by Dr. Ravi Mohan sir, sincerely speaking, to speak in favor of TURBT, sincerely speaking, I was actually surprised that do I really need to defend TURBT as there is huge data to support it. But after going through the literature, I came to know that there are emerging data for en bloc resection of bladder tumor. So for practical purposes, I am here not to debate, rather to put facts and data as of today, which are available, and I would leave it to the experts and audience to choose the modality. So the TURBT was started it's in infancy by the NIDS, and it was first done completely by the McCarthy and Envelop, who first removed the tumors of the bladder using the resectoscope. So what are the indications and the advantages of the TURBT or the standard TURBT is that it provides accurate information with regard to the bladder tumor grade and local stage, and it treats superficial bladder tumors supplemented by intravesical chemotherapy and immunotherapy. Moreover, it palliates symptoms such as a bleeding in invasive cancer where the cystectomy or radiotherapy is not possible or not appropriate. Also, it debulks large tumors prior to radiotherapy, as Dr. Vedamurthy has already mentioned in his talk. So I would skip these slides to the patient's workup and initial cystoscopy, examination under anesthesia, followed by the TURBT, which starts first to aim to expose the tumor. After that, the tumor is superficial part is resected, and once the stalk has been found, roller ball is used to coagulate the main vessels, and then trimming, and finally the deep resection or the resection of the deep muscles is done. So there are various approaches to the standard TURBT, like horizontal approach or the vertical approach, or by dividing the stalk first. So there are few circumstances or places where the standard TURBT clearly holds an upper position in comparison to the en bloc, that is the difficult positions like anterior wall and the dome, and the tumors in the diverticula, especially in the tumors in the diverticula where the muscle is not present. Their en bloc resection, I don't think is possible at all. So I would not go left, right, and center. I would directly quote this editorial comment, fine editorial comment that states with its heading like en bloc resection of the bladder tumors, style or substance. So the crux of this editorial comment or this article was that they stated clearly that unfortunately high quality data on en bloc removal of the bladder tumor are lacking, and available studies are hampered. They said that available studies are hampered by a lack of standardization of the patient selection technique and outcomes measured. So they showed that the present study, 10 RCTs were involved with a total of around 1100 patients with equal distribution of the patients in each arm in ERBT and TURBT. And they concluded that due to the differences in outcome reporting, only a subset of these studies contribute to the pooled outcomes. So they included only the randomized control trial, and they excluded the observational studies in an attempt to reduce the selection bias. The authors, they reported that, yes, they reported that fewer bladder perforations were there in ERBT and shorter irrigation time. But again, it is to be taken care, or it is to be concentrated that only 5 studies they reported fewer bladder perforation, and only two studies they reported shorter irrigation time in ERBT in comparison to the TURBT. So in addition, they also concluded that it is uncertain if the lower perforation rates of en bloc removal of the tumor is actually related to the surgeon comfort with the novel technique, or as an early adapters, or whether in the future widespread use would show the similar results. So this is a question. Still, it's a question whether the lower perforation rates and shorter irrigation time is actually the benefit of the ERBT or not. Similarly, as Dr. Vamsi has also mentioned, that authors noted that equivalent recurrence rates at 12 months, 2 years, and 3 years, and but they forgot to mention it that only 5, 2, and 3 studies respectively were succeeded to include these outcomes. And finally, the authors concluded after the meta-analysis of these randomized trials that the data are unfortunately too limited for subgroup analysis between ERBT modalities itself or the patient and disease factors. So the main novel contribution told by the authors of this analysis, they said that the paper is a qualitative process. Just please note down that the paper is a qualitative process whereby the authors compiled 99 statements and they presented them to a panel of experts for consensus development. So in fact, the fact itself that a consensus process is required to interpret the existing en bloc removal of the bladder tumor data itself shows that how poor these data really are. An additional concern was that the constitution of the expert panel for this interpretation. So members were chosen either as authors of ERBT systematic reviews itself or as respondents to an online advertisement with verified personal ERBT experience. So consequently, the conclusion was that the panel was itself heavily skewed towards the urologists practicing in Europe and Asia who are early adopters and believers in ERBT, and it doesn't represent the whole world. Then coming to the main said ERBT benefit is avoidance of piecemeal resection of the TURBT that is thought to lead to seeding of normal urothelium by tumor cells shed during the resection. Actually, the existing evidence does not support the notion as of now that ERBT reduces the recurrence. In addition, ERBT may not be appropriate for many bladder tumors, as Dr. Vamsi himself has accepted that includes the tumor for more than 3 centimeters, multifocal tumors, flat tumors, and tumors which are located in a difficult position like dome or the diverticulum. Again, that specimen retrieval is also a major limitation because even after a nicely resected en bloc resection, the tumor might be impossible to extract intact through the resectoscope sheath without an additional equipment like morcellation, etc., which is not routinely available. Again, Dr. Vamsi has himself accepted that in many reports, they have mentioned that dividing the tumor after the en bloc resection, then the whole purpose of the en bloc resection is defeated itself. And morcellation again defeats the purpose of the en bloc resection, followed by a deep resection with the loop. If it is at all required, then the whole purpose of the en bloc resection is defeated, in my opinion. So the most recent and the comprehensive systematic review and meta-analysis identifies the 10 RCTs comparing the ERBT with the TURBT. And the major limitations of these trials were a low individual sample size, heterogeneity in outcome reporting and treatment like energy source use, post-operative management, etc. So these the meta-analysis of the RCTs was not able to show any difference regarding catheterization time, hospital stay, occurrence of the obturator nerve reflex, presence of the detrusor muscle in the specimen, and the recurrence rates. So again, whereas the direct improvements of the certain clinical outcomes by ERBT are suggested by numerous clinical studies, mind it, numerous clinical studies, not the RCTs, it was concluded that pathological and translational studies are still limited. And the major current limitation of ERBT still remains the extraction of the large en bloc resections, which are generally more than 3 centimeter tumors. So I would like to conclude my talk that yes, there are accumulating evidence which are indicating that ERBT or en bloc resection improves the quality of the surgical specimen and decreases the re-TURBT frequency. But still, the future large-scale, high-quality RCT are lacking, and they are needed to confirm the superiority of this technique over the TURBT. So, to conclude with, still the standard TURBT is gold standard, and to determine whether the ERBT should replace conventional TURBT as the standard of care, it will require more results from high-quality RCTs without any biases. ERBT, yes, may have a role in the smaller tumors, but larger tumors and the tumors located in the difficult situation and again in the training institutes, standard TURBT still has a role and will have a role. Thank you. Thank you very much.
Thank you, Himanshu, and Dr. Vamsi's apologies for not being able to show your video for those nice talks. So we have 2 experts from again one of the 2 great institutes to present their expert comment. Professor Amlesh Seth sir is from AIMS New Delhi. He would, and followed by Professor Uttam Mehta sir from PGI Chandigarh. So over to you, Seth sir.
Thank you, Ravi. Thanks for this opportunity. I congratulate both the speakers for bringing out the literature very well. But practically what we need to see is what are the cases that we actually come across. And although en-bloc TURBT sounds very attractive, and we should get a very good pathology specimen, especially the invasion of the lamina propria and muscularis should definitely be better seen in en-bloc TURBT. But practically, what percentage of tumors are actually amenable to en-bloc? The tumors that are large, and if you have to do morcellation, the whole purpose is defeated. If the tumors are in the dome, again, it's very difficult. Lateral, only the ones that are posterior lateral, they are the ones that are, and those two that are small. Mainly, TURBT is for posterior wall tumors, small with well-defined pedicle. If the pedicle is not well-defined, if it is big and has a diffuse big base, then again it becomes a problem. So practically en-bloc, and the other thing is, limitation of devices. You see, you look at the ophthalmology literature of this LASIK surgery. They have very precise lasers. And you look at the GI endoscopic dissection of the polyps. They also have so many types of snares, etc., etc. And unless we actually develop very good quality instruments, which are practically usable in most of the situations, or we need actually a separate device for each situation. And without that, I think EBRT, en-bloc TURBT would remain confined to small tumors with well-defined pedicle.
Thank you, sir. Uttam, sir.
Thank you, Dr. Ravi, and of course, UroOnco section of the USI. Though I'm going to talk as a last person, but not the last word, definitely. So what I'm telling, see, because from my own personal experience, unpublished data, I must say that ERBT is the one which one has to choose, especially in the training institute. See, the main purpose, even at the time of retirement also, I have seen people are perforating bladder and they feel sorry. And this is all because of the electrocautery which you are using. But if you use laser, now the question is, when you are going for ERBT, not only the question of the technique, but which energy you are going to use. Now, if we want to use laser, then I think that is the most effective one. So if you use laser, no perforation, no jerk. So no question of being sorry at the end of the procedure. And as we know that most of the urologists are using laser for their stone surgery. So the same armamentarium is still there. And whatever instrument we are using, only you need a laser guide. That's it. So no extra cost, no extra burden to the department. So that way it is okay. But what Dr. Himanshu was telling, yes, there's no RCT to tell that this is superior. The en-bloc resection is superior. So there are two things. One is en-bloc plus the energy which you are going to use. If I say that, yes, you are going to use laser, definitely it is superior. No perforation in my own experience, no perforation, no bleeding, nothing is there. Only thing is the quality of specimen. The quality of specimen, what do you mean by quality of specimen? Is it going to give only the layers, nothing or more than that? That's what I want to add. It is not only the layers also, it is the charring. What we get, the pathologists get the charring when you use the electrosurgery. So, but if you use this laser as for en-bloc dissection, there will be no charring or minimum charring, and the orientation of the specimen will be very good. So if you want to leave the TURBT to a resident, if you have the laser in your armamentarium, please leave it to them with the laser only. They are going to learn better. Thank you very much.
Thank you, sir. Thank you. And thank you. My apologies to USI for overshooting the time. And I would request Dr. Amit to have the concluding remarks from the subsection.
Thank you, Ravi. Actually, thank you everybody for giving us this opportunity to host this very special inaugural session of UroOncology section of the USI conference. Ravi, Ganesh, Bakshi, Santosh from Vellore and myself were first given this task to set up this subsection. We had started with enthusiasm, and the biggest enthusiasm was that huge response, both in the way of membership and tonight. We are very thankful to each and every participant for having participated in the inaugural session in a big way. 2 or 3 lessons that I have learned today is that huge participation, over 100 members actually participated. Just after 9 o'clock, it dropped to 70. And now it has dropped to closing to 50. The first lesson is, I promise the next session that we are going to do will be 1 hour and 15 minutes with a spare time. If it is in even Indian Standard Time, we will not cross 9 o'clock so that we can retain the 100 members as audience. That has been our fault. It has been an inaugural, my excuses, it's the inaugural session. And therefore, we all have learned our lesson that though it was very, very rich presentation, we must end on time because we all love our dinners and we have a work to do tomorrow. The next session will be in August and the next session will be in September. These are the 3 sessions that we will do before we have an ambitious plan of on the 5th of November to do a physical UroOncology meet. Probably the next session will be on omics and the next session will be on advances in neuroimaging. It may be a topsy-turvy, we haven't decided. We are hunting for very good participation and speakers. We will let you know and you will get an announcement within the next 3 to 4 days so that we have your active support in participation. Wonderful session today. Thanks to Ravi who has done the hard work with everybody's support. We wish that everybody blesses us that this UroOncology actually expands even more. With those few words, I don't know whether Ganesh and Santosh would like to chip in their few little bits of comments, and then we close.
I think we should just finish with Ravi's comment here. And yeah, Gagan, please.
Nice.
Gagan, please go ahead.
I'm not Gagan, I'm Ganesh, by the way. And I think this was a good session. So, as Dr. Amit said, we should limit the time a little because it goes beyond practice time of people, lunch, dinner, whatever. But we really enjoyed the scientific content here, and that is more important. So, let's meet in future again.
Yeah.
That's
it. With permission of Ravi, may I take this opportunity to thank everybody and close tonight's session. And we look forward to having you again in August, sometime between the 15th to the 21st. It may probably be the 15th. Good night, everybody.
Good night.
Thank you and good night.
Good night. Thank you.
Good night, sir.
Good night, everyone.